So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event, jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Forum of Cardiac Anesthesia, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation USA chapter. The focus of today's session is the ultrasound of airway assessment. And to start with today's session, I would like to present before you a short welcome video.
Good morning and welcome to everyone present in this meeting. Thank you for joining us. Today we have an exciting session on ultrasound for airway assessment. And before I request my faculty, that is Dr. Shivakumar and Himaldev, to start the session, I would like to mention that this is being conducted under the auspices of Indian College of Anaesthesiologists, Indian Association of CT Surgeons, and a few other organizations who are supporting this activity. And the question answers will be at the end of the session. Please put your questions on the chat box. We will address all the questions as within the time limits. And any comments are also welcome. Till that time, keep your mics muted. And thank you so much for joining. And I will request Dr. Shivakumar to take over. Shivakumar is a consultant intensivist at Narayana Hridayalaya. He is extremely interested in echocardiography and ultrasound in critical care units. I think Shivakumar will introduce Himaldev and then the talk will ensue. Please stay till the end because there are some announcements to be made at the end. Thank you so much. Dr. Shivakumar, please take over.
Thank you, sir. Very good morning to everybody for the Sunday breakfast tea session. So today we have Dr. Himaldev, who's a lead consultant and ICU head of intensive care of Apollo Hospital, Sheshadripuram. He's very well known among the intensive care doctors in the Bangalore circle. He's an expertise in critical care, echocardiography, and ECMO. He's going to talk to us about use of assessment of airway. As evaluation of airway with ultrasound forms an important aspect especially in critical care setup where we have a difficult airway or we want to do a tracheostomy. Dr. Himal is going to take us through the lecture, and any doubts you can always post in the end of the session. So over to you, Dr. Himaldev.
Thank you, Dr. Shiva. Thank you, Dr. Muralidhar sir, for the kind introduction and giving the opportunity to speak on this podium. Good morning, everyone. Prishu, I'll just say the screen, just see whether it's visible to you.
Dr. Hima, you can proceed.
Can you see the slides moving?
Yes, yes.
Okay, good. Okay, so today's breakfast session is on the ultrasound for airway assessment. And if you looked at the introductory video, we saw all echocardiography, ultrasound for vascular access, but I didn't see ultrasound for airway assessment. So everyone must be wondering, what are we doing today morning looking at ultrasound? Can ultrasound be useful in airway management? And I was wondering the same many years ago. But if you look at the variety of clinical cases or clinical scenarios where you can use ultrasound, especially in airway management, is humongous. Okay, you can actually broadly categorize it to three aspects. And the first aspect is the emergency one, where you need an emergency airway, where you locate the cricothyroid membrane for a cricothyrotomy. And simultaneously, you can also do a percutaneous dilatation and tracheostomy by using this ultrasound access. The second profile is you look at the endotracheal tube sizing, especially in pediatric patients, so they can avoid subglottic stenosis, which can be a disastrous complication in them. You can also use it as a method for endotracheal tube placement, which is very interesting, which we'll go through the slides. And you can use it for predicting the post-extubation stridor. Again, one of the reasons why the patients get re-intubated and a prolonged ICU stay, prolonged ventilation, and morbidity and mortality. You can also use it as a tool for assessing the difficult airway and also predicting the difficult airway. Sometimes we can also use it for placement of double lumen tube and also probability of OSA, so that we can prognosticate the patient and you can assess them and you can assess the need for BiPAP and airway management in these patients. The third aspect is you can also look at the vocal cord movements. You can also evaluate the epiglottis in the case of epiglottitis. And these are certain situations where you can use ultrasound. So let us delve into first management, that is how do we do a cricothyrotomy by using an ultrasound, and how do we identify a cricothyroid membrane? If you look at this article by Vijay, the success rate of a real emergency airway access is only 36%. The main contributor for this is because you're not able to identify the cricothyroid membrane. And identifying this membrane in obese has a success rate of 0 to 39% itself only. But if you do a proper training with ultrasonography, the identification of cricothyrotomy becomes close to 100%. And they continue to say that identifying this membrane before commencing any airway management is essential. There are two methods of identifying the cricothyroid membrane by using ultrasound, which I'll show you in the slides. One is a TACA method, that is a transverse method. The other one is a longitudinal method. So if you use these two methods, the identification time will be around 24 to 37 seconds. So that's why ultrasound is helpful. So before going into the details of how do we do the ultrasound measurements, I'm sure we all know about the anatomy of the airway. If you look at it, can you see the cursor, Dr. Shiva? Are you able to see this cursor moving around?
We are able to see the cursor.
Okay, wonderful. So you can see the hyoid bone here, and the compartments above is suprahyoid and the infrahyoid compartment. Then you can see a wonderful thyroid cartilage here, and the membrane connecting the hyoid and the thyroid is the thyrohyoid membrane. Then we have a cricoid cartilage here, and the membrane which is connecting between these two is the cricothyroid membrane. This forms one of the bases for most of the airway anatomy. If you go down further, you can see the first tracheal ring, second, third, and subsequent tracheal rings. This is where we do a cricothyroid membrane. This is where we do a cricothyrotomy. And this is at the level of second and third tracheal ring. This is where we do a tracheostomy. You can see a thyroid gland here and the thyroid isthmus. This is the transverse section. And if you look at the longitudinal section, the same way, you can look at the thyroid cartilage here. Go down further, you can see the cricoid cartilage, and you can see the tracheal ring subsequently. Okay. So if you know about this anatomy, the ultrasound assessment becomes much easier. If you go further, you can see the 3D structure here. This is the thyroid cartilage, and this is the thyrohyoid membrane above it. And this is the cricothyroid membrane, which is connecting the thyroid cartilage to the cricoid cartilage. This is the first tracheal ring and the second tracheal ring, and you can see a cricotracheal ligament. So we do a cricothyrotomy here, and generally between the second and the third tracheal ring, we do a tracheostomy here. Okay, so that's the anatomy. And what kind of ultrasound probe we use in a case of airway assessment or airway ultrasound? We usually use high frequency linear probes so that we can see the superficial neck structures better way. So you can either keep it horizontally, that's called horizontal or transverse view, or you can also keep it longitudinal, and we can look at the longitudinal view of the structure. So this is a horizontal view. You can see it has been kept transverse over the neck, and this is what you see when you keep the probe. Okay, what are the structures seen here? You can see air-filled tube here. This is the trachea. You can see two vessels here. This is the jugular vein, and this is the carotid artery. And if you go further down, you can see the lobes of thyroid gland here, and you can see some vessel. It's a pretracheal vessel here. And you can look at a beautiful air fluid interface. This is generally formed in a case of a cricothyroid membrane or any tracheal region, and because of that, there is a reverberation artifact, and there is a comet tail artifact, and there's a posterior shadowing. So in a whole, if you put a probe in the transverse position in the neck, you're going to see these structures: the two vessels, the airway, the thyroid, and the pretracheal vessels. This is in the transverse horizontal position. But what if you put the probe in the longitudinal position? That is, if you place the probe this way. So you can see the structures in the longitudinal section. So you can see this. You can see the structures like this. These are called a string of pearls appearance. You can see the tracheal rings, which look like string of pearls. So if you place the probe this way, longitudinally, you're going to see the string of pearl appearance. This is how you can delineate it on the string of pearls. These are the ones which forms the tracheal rings. And this part is the thyroid cartilage, and this is the cricoid cartilage, and there is a cricothyroid membrane connecting to it. This is how you identify the cricothyroid membrane. And we do a cricothyrotomy here and the tracheostomy between the second and the third tracheal rings. This is the air fluid interface which happens. And generally, one of the assessment is to look from the depth of the skin to the cricothyroid membrane so that you know how much of the needle is entering that, so that you don't punch over the deeper structures and cause more complications. So you can actually measure the depth of the needle penetrating the cricothyroid membrane. I told you there are two methods of identifying the cricothyroid membrane. One is the transverse method, also called as the TACA method, and the other one is the longitudinal method. It's very simple. Basically, the name itself tells us. TACA is first you place the probe on the thyroid cartilage, identify the thyroid cartilage, that is T. Then you go down and place it near the cricothyroid membrane, and you can see a white line here, that is the air line that forms the A. Then you further go down and see the cricoid cartilage. This is a structure. And once you confirm this, you go back up and look at the airline again, reconfirm it, so that the cricothyroid membrane is identified and you do a cricothyroid. So that is called as TACA. Thyroid, come down airline, come down cricoid, and just move up again and confirm the airline back and confirm the cricothyroid membrane. So this is how it looks. So this is what we showed. You put the probe in the horizontal position at the level of thyroid cartilage here. You can see this beautiful structure here. A triangular hyperdense structure. What is this? This is the thyroid cartilage. And you can see a soft pillow-like structures here. There are arytenoids. So once you identify this, this will form a landmark to you. You come down further a little bit. You see the horizontal probe here. You can see a white line. This is the air mucosal interface, and you can see a comet tail artifact here. This forms the cricothyroid membrane. Come down a little bit further. See the horizontal layer down here. You can see a circular structure here, semicircular structure, hyperdense. This is the cricoid cartilage. So you confirm the cricoid cartilage, you move up a little bit, and you reconfirm the cricothyroid membrane. So this is how you identify. Once again, I'll tell you so that you won't miss it. You find the thyroid cartilage, come down and identify the cricothyroid membrane, come down further and confirm the cricoid cartilage, and go up one step and reconfirm the cricothyroid membrane. So this is how you identify the cricothyroid membrane before cricothyrotomy. Longitudinal, I showed you. Whenever you place the probe on the longitudinal position, you get this string of pulse appearance. But before that, what you need to do is, when you place the probe longitudinally, you get the string of pulse appearance. So first you identify the trachea by putting the probe in the tracheal site horizontally. Then you slowly rotate the horizontal probe towards longitudinal position and you get the string of pulse. Just take the probe a little bit upwards and you can find the cricoid cartilage and this is the cricoid cartilage and this is the thyroid cartilage and this is the cricothyroid membrane and this is where the needle goes in. So that's how we identify the cricothyroid membrane in the horizontal position and also in the longitudinal position. Horizontal position is called as TACA and longitudinal is nothing but the string of pulse method. And you know, cricothyrotomy is very essential whenever you can't get an access to the trachea or there's a difficult airway scenario, especially when there is a large thyroid or there's a Ludwig's angina. This becomes an emergency airway management and life-saving technique. And we can use ultrasound as a very good guide to put the tracheostomy tube inside by a serial dilatation technique, and you can use a cricothyrotomy set, and you can actually ventilate the patient. So I hope this is clear. This is one of the essential things which basics everybody should know, at least identifying the cricothyroid membrane. The next we'll go to everybody's favorite. I think all ICUs are practicing percutaneous tracheostomy now, which is preferred more than the open tracheostomy because it can be done at the bedside. It is faster. It involves lesser tissue dissection, and so there is less chance of bleeding. There is less chance of infection, and it can be cost effective as well. And there is a trend actually, if you do a percutaneous tracheostomy, there can be a reduced number of ventilation days and reduced ICU stay as well. But no strong robust data, but definitely percutaneous tracheostomy is preferred in most of the intensive care unit patients who require long-term ventilation to aid weaning. But there are certain contraindications where there is a difficulty and there is a large masses around the neck or a short neck. In all these situations, probably surgical one is preferred, but generally we also do a lot of percutaneous tracheostomy in it. But everybody wants to do it. But when you know about the problems or complications of percutaneous tracheostomy, then only we'll understand how disastrous it can be. As we say, ignorance is bliss, but we need to know the complications so that we can address them. But if you use ultrasound, even in percutaneous tracheostomy dilatational technique, we can avoid all these complications. So if you look at it, what are the complications we can anticipate? We can cause a tracheal laceration if we don't put the dilatation properly. If the needle goes into a different side, it can cause a paratracheal position and can cause other structures, injuries. It can go through and through to the trachea and can cause esophageal perforation or laceration. Sometimes if you go lower down, you can hit the pleura and can cause pneumothorax. Multiple times we have seen this. You need to be identified immediately and dealt immediately. Sometimes you can puncture the vessels which are nearby to the trachea, like carotid or internal jugular vein, and can cause torrential hemorrhage. Sometimes there are vessels which are lying above the trachea, pretracheal vessels. They can get damaged and they can also bleed. And sometimes one of the disastrous complications is innominate artery injury, which can also bleed torrentially. So you know these structures are going to be there. These are the complication anticipated. We can use ultrasound, delineate these structures, and you can avoid any complications happening because of this thing. And you can do a beautiful percutaneous tracheostomy technique by using this Seldinger technique. We generally use this technique. This is the Seldinger blue rhino dilatation technique, where you actually place the needle by using ultrasound guidance. And sometimes we also take the aid of bronchoscope as well, but that is not mandatory. It's not a gold standard as well. So you place the needle, confirm the position, put the guide wire, and just like how you put in a central line through the Seldinger technique, you dilate it through the serial dilators, and you pass the tracheostomy tube into the trachea. So while doing this, we can take the help of ultrasound. This is how you plan and puncture and do the screening in a case of percutaneous dilation technique, which I'll show you through the series of slides. First thing is you need to identify the tracheal rings. I showed you this before. You put the ultrasound probe horizontally, the high frequency linear probe at the level of thyroid cartilage. And what you're going to see is a beautiful hypodense thyroid, hyperechoic thyroid cartilage. The triangular shape, you can't miss this at all. The moment you put it on the thyroid area, when you feel the thyroid with the finger and you place the probe at the level of thyroid cartilage, you can get this triangular space. Go further down, as I told you, you can get the circular structure, hyperechoic. This is the cricoid cartilage. And go further down, you can get this air mucosal interface, which are nothing but the tracheal rings. And this is where you're going to place your needle. So that forms the landmark for your needle entry. Running through you once again so that you can understand it better. For the new, at least freshers, probe at the thyroid, you get the thyroid triangular structure. Probe at the cricoid, you come down, you get the circular, semicircular cricoid structure, cricoid cartilage, and you run down further, you get the tracheal rings. So this is what we do before a tracheostomy. Once you identify the tracheal rings, what we need to do is you need to screen the entire neck before that, and you need to find out if there is any vessels, pretracheal vessels lying in front of it, because if you go through it, you can puncture it and it can cause a lot of bleeding. And during the procedure, it can cause a lot of problems, and the procedures can get delayed. But if you know it, then probably we can prepare it to either ligate these vessels or cauterize this vessel, or you can avoid this vessel and enter the trachea. And also you need to have a lateral safety margin. You know there is a jugular vein and the carotid artery lying at the lateral side. So you make sure that you know where is it so that you don't puncture these vessels. And you can also look at the innominate artery and confirm that there is no major vessels when you perform the tracheostomy. You also look at the distance from the skin to the trachea so that you know the needle entry, because you don't push the needle too much inside so that you don't puncture the posterior wall of the trachea and puncture the esophagus and can cause esophageal injury or esophageal laceration or tracheoesophageal fistula at a later stage. Furthermore, after this horizontal position, I told you make it longitudinal, and when you do a longitudinal probe position, you get the string of pearls appearance. These are the tracheal rings, and you can see a classical endotracheal tube, which is lying in the trachea. So if you do the procedure with this tube in situ in the tracheal rings, you can puncture the cuff, and again you can have a loss of airway, because you know during the tracheostomy the airway maintenance is very important. So you need to ventilate the patient. So in that case, what you need to do is you need to pull the endotracheal tube back slowly under the ultrasonic guidance, and the tube cuff lies above the level of the tracheal rings, maybe near the vocal cords, so that when you puncture the tracheal rings, you don't puncture the cuff. So you can see in this picture here, the endotracheal tube is lying maybe near our second or third tracheal rings, which has been slowly pulled out further, and it is lying somewhere here. So you can easily puncture the tracheal ring and perform the tracheostomy. So once you do all this, quite simple, under the ultrasound guidance, we can puncture the trachea from the skin to the trachea through the needle and enter the tracheal space. You can see the needle here, which is entering the trachea at the 12 o'clock position. This position is ideal because the more lateral you go, you're going to puncture the lateral structures. Then once you puncture the needle, you know, of course, you put the guide wire inside. You can see the guide wire going into it. And after that, you do a dilatation and put the endotracheal tube inside, or tracheostomy tube inside, and you can see the tracheostomy tube cuff here. So you know there is the procedure is complete, you know tube is inside, but how do you know you have not caused any complications? So simultaneously, when you have an ultrasound probe, what you can do is, I'm sure everybody knows, I'm sure everybody heard about this ultrasound lung. So we do a lung screening and you look at the pleural slide or lung sliding. If there is no pleural slide, absent lung sliding, that means there is a component of pneumothorax and you may have to identify it. And if there is no lung sliding, of course, we look at the lung point, which reconfirms there is a pneumothorax. And simultaneously, we can know the complication of tracheostomy as well. So this is how we perform a tracheostomy, percutaneous dilatation tracheostomy under the guidance of ultrasound, and avoid major complications. You screen the vessels, you have an anatomical location, and you have a real-time guidance of percutaneous insertion of the needle and the dilatation, confirmation of the tube, and finally, after the confirmation of the tube, there is no pneumothorax, which is confirmed by presence of lung sliding and absence of lung point. So this is an elaborate description of percutaneous tracheostomy. by using ultrasound guidance. Now it is being used extensively in almost all the ICUs. I'm sure every ICU has an ultrasound now, and this is how you prevent complications of percutaneous tracheostomy. So these two studies I found interesting. The target study and the tracheostomy trial, randomized trial. The target is nothing but the traditional landmark versus ultrasound guided evaluation trial by Din et al. Found that real-time ultrasound guidance improves the success rate of first attempt at the percutaneous tracheostomy and puncture compared to a traditional anatomical landmark. Similarly, Gabato et al. Also in tracheus RCT suggested that if you use ultrasound guided percutaneous tracheostomy, it is as good as bronchoscopic guided percutaneous tracheostomy. And when compared to the conventional landmarks, we go by using a landmark technique. Ultrasound is, it has a higher success rate with shorter time to successful cannulation. So both the studies, they favor usage of ultrasound technique. And if you have a bronchoscope, again, that is an additional tool, we can use it. So we can accurately know that the guide wire and the needle and the guide wire is exactly in the trachea. You don't puncture the posterior wall. And it is a double reassurance that the tube is in the tracheal rings. The tracheostomy tube is in the tracheal rings. But it is not mandatory. We can use an ultrasound itself and we can do a percutaneous tracheostomy. So that's about cricothyrotomy and the tracheostomy. Where all we can use ultrasound. This is one important aspect in the intensive care unit or in the post-op surgical care unit. We use ultrasound, that is mainly to determine or anticipate post-extubation stridor. And how do we do this? So there is a measurement called as air column width. So ultrasound, maybe it will be able to assess the air column width. I'll tell you how to do that air column width. So we measure the air column width with the cuff inflated and cuff deflated. And the difference, air column width difference, if it is less than 0.8 millimeter, it is associated with post-extubation stridor. So that you know that if you extubate this patient, he is going to have a post-extubation stridor. So you can take a necessary precaution. Maybe you can explain about the possible reintubation to the family, or you can also prepare for actually reducing the edema by using certain medications like steroids or adrenaline nebulization. More stringent monitoring techniques should be applied for these patients, or we can delay the extubation for quite some time if you can assess the post-extubation stridor in these patients. So this is how you do it. An air column width difference less than 0.8 millimeter was associated with post-extubation stridor, and sensitivity is 93 to 86%, specificity is 86%, and accuracy of 91%. We also do something called as a cuff leak test, but it is a very poor technique, and it doesn't accurately determine the post-extubation stridor. Ultrasound is a better way. And how do we do this? We place this linear high frequency probe at the level of thyroid and look at the vocal cords here. You can see the vocal cords here. Dr. Shiva, can you see the slides and the cursor moving?
Yes, Dr. Iman.
Okay, so you look put the probe transversely at the thyroid level and look at the vocal cords. And when the endotracheal tube is inside the cords, you can actually measure the air column width. This is when the cuff is inflated, and this is when the cuff is deflated. And you measure the column width and you look at the difference. If the difference between these two is less than 0.8 millimeter, this patient is definitely going to have a post-extubation stridor. So you prepare yourself accordingly. Alternatively, we can also use this to measure the endotracheal tube size, especially in pediatric patients. So the outer diameter of the best fit endotracheal tube should be less than the subglottic diameter. This is how you measure the subglottic diameter at the level of cricoid cartilage in the transverse position itself. It should be lesser than the subglottic diameter at the cricoid level by at least 0.1 to 1.7 millimeter. It should not snugly fit into the cricoid level. That is the one which is responsible for subglottic stenosis. Not only in children, we have seen a lot of patients with subglottic stenosis who have been intubated outside with a bigger tube, or maybe an emergent intubation, a traumatic intubation, and a long-term intubated patients. They go into a bad subglottic stenosis, and it becomes a morbid state. They need to go through a recurrent tracheal stenting, tracheal dilatation. It becomes very difficult for them. So that's why we need to be very careful before intubation to select the right tube and make sure that you don't injure any of the cricoid or the vocal cord structures, which can cause subglottic stenosis later on and form problems later on. Okay, so it avoids tracheal wall ischemia, ulceration, necrosis, and tracheal stenosis in long-term patients. So 3 things we finished. The fourth one is an interesting one, which I also found. We can use it as a successful or a wonderful tool to know the successful endotracheal tube placement. So endotracheal tube can be visualized in the trachea. This is the transverse view I showed you before, and this is the longitudinal view. We can see the endotracheal tube as a double tract here, and you can see an endotracheal tube here in the longitudinal position with a sensitivity of 98% and specificity of 98%. Esophagus can also be visualized. You can see the diagram here. There's a tube in the trachea here, and you can see the reverberation artifacts. This so this is called as a bullet sign. You can see only one shadow here. But if you look at here, this is an esophageal intubation where you can see the trachea here, but you can see also a tube in the esophagus. So this is called as a double barrel or double track sign in the case of a transverse view, in the case of ultrasound, where you can see a clear esophageal placement of the tube. This is a very sensitive technique. And you know, when it is useful, this is how you see the double sign in a case of endotracheal tube placement. That confirms the tube is in the trachea. So summarizing, you put the ultrasound probe suprasternally, okay, and you can see the tube is in the trachea, and you can see a classical comet tail artifact because of the tube here, and there is something called as a posterior shadowing. This all looks like a bullet. So this looks like a bullet sign. This confirms the placement of endotracheal tube. This can be done real time so that you don't miss out a esophageal tube placement. Suppose you see this sign where you can see 2 comet tail artifacts and 2 posterior shadowing. This indicates that there is a esophageal placement of the tube, indicating that there is a double tract sign, also called as misplacement of the tube in the esophagus. This is how you confirm the false placement of endotracheal tube into the position. We'll run through a case scenario where you'll understand it better, because it is one of the very good tool, and even some of the society recommendation says that ultrasound should be used as a tool in diagnosing correct endotracheal tube placement. Coming to final usage of ultrasound, you need to assess the difficult airway, and we can use this tool beautifully. So there are multiple criteria. Among these criteria, we can take 3 important criteria, that is tongue thickness, hyomental distance, and hyomental ratio. So these are the main things which actually determine the difficult airway prediction and assessment of difficult airway. How do we do it? So this is a beautiful slide showing you 5 views. This forms the basis of airway focus, that is airway point of care ultrasound. So the first one is a suprahyoid view. This is a hyoid bone here. So when you place the probe longitudinally, you get the suprahyoid view. This is a thyrohyoid view, where you place the probe horizontally. Then the thyroid view, which is used to look at the vocal cord function. The fourth one is the cricothyroid view, which I showed you to look at the cricothyroid membrane. And the fifth one is the suprasternal view, which we just discussed about the endotracheal tube conformation, where you see the bullet sign and the double barrels. So by using these 5 views, actually you can do a complete airway assessment, and it forms a very good basis for point of care ultrasound in airway. So this is the first view, suprahyoid view. You place the probe longitudinally above the level of hyoid, and you see this distance. This is the hyomental distance. This arrow marks the hyomental distance, and this is the tongue, and we can also measure the tongue thickness through the same view. Hyomental distance, it is a quantifiable measure of cervical spine mobility during hyperextension, and it can be measured in neutral position and hyperextended position, and you can take a ratio of it. Similarly, tongue thickness itself is a marker for predictor of difficult intubation. If it is more than 61 millimeter, indicates that it can be a difficult airway. That is about the suprahyoid view. If you go to thyrohyoid view, we can see something called as the distance from skin to epiglottis, because especially in the case of thick neck or a lot of soft tissues in front of the neck, intubation becomes difficult. So again, this is one of the predictor for difficult airway. The preglottic soft tissues, especially distance from skin to epiglottis, indicator of a difficult airway. And if you do all these things, there is something called as a Dale's protocol. So we have 4 weaves, and in these 4 weaves, what we did was, I told you, in the thyrohyoid weave, in this weave, we measure the distance from skin to epiglottis. If it is more than 2.4554 centimeters, it is an indicator for difficult airway. Then we measured something called as hyomental distance. In the suprahyoid weave, we measure the hyomental distance and the tongue thickness. So you measure the hyomental distance and the tongue thickness. If the hyomental distance is less than 5.29 centimeters or the tongue thickness is more than 61 millimeter, again, difficult airway. We can do this suprahyoid weave and look at the hyomental distance in the extended position and the rammed up position. And you can take a ratio. If the ratio is less than 1.08 and or 1.12 subsequently, then it is a difficult airway. So it's very simple. Thyrohyoid weave and suprahyoid weave measure the distance from skin to epiglottis, hyomental distance, and tongue thickness. Use this formula. By using this Dale's protocol, you can actually have a prediction of difficult airway, and you can plan your intubation or airway management accordingly. Sometimes we can use a condyle translation by using ultrasound, which is less than 10 millimeter. And even OSA can be identified by using ultrasound probe. That is, we can use a distance between the lingual artery as a marker, and you can assess it. Also, you can also use the retropharyngeal space. This is a little beyond scope of the talk, so I'm not talking in detail about it. If you know the basics, that's enough. Along with this, we can also look at the vocal cord movement, especially the pre and post neck surgery for the superior laryngeal nerve function. And LMA placement can also be assessed by using ultrasound. In a case of epiglottitis, which can be a marker for a difficult airway later, can be assessed with this. And it can also be used for superior laryngeal nerve block, especially during the awake intubation and double lumen placement tube. It can be used. So the main uses are, as I told you, an emergency airway to get an access for cricothyroid space, cricothyrotomy, and percutaneous dilatation tracheostomy. You can also use it to know the post-extubation stridor. You can use it to know the endotracheal tube placement. And you can also use it as one of the beautiful modality to assess the difficult airway in assessment, difficult airway assessment. So that concludes the usage of ultrasound. But I'll run you through a case scenario where you can use it in a better way to delineate this endotracheal tube placement, and how do you manage a real-time sick patient by using ultrasound assessment of the airway. So we have a young man. Unfortunately, he had a road traffic accident. He was brought to the ER. He was hypotensive. He was hypoxic. And an ER resident intubated him. So post-intubation, SpO2 is steadily declining and he is hypotensive. So the senior doctor asked him, "Are you sure the tube is in? So did you see the direct vision?" He said, "I think so. I'm not very sure, but I think it is in the direct vision. I'm not able to see the condensation properly. I don't have the ETCO2 probe available. And as you know, ETCO2 may not be very reliable, even if it is available in the low perfusion state or in a cardiac arrest scenario, then the ETCO2 may not be very reliable. Did you auscultate? No, I'm not very sure, because his thick chest, maybe severe bronchospasm, auscultation is not very reliable. X-ray, of course, it will take a lot of time by the patient. By the time it comes, patient will be dead. So how do we determine the endotracheal tube position in this patient? So what if we had an ultrasound probe and we all knew that ultrasound can be a useful tool? We could have done that. And I'm sure tube must be in the wrong place because there is saturation which is not picking up. So either it can be 3 places. Either it can be in esophagus, or it is too outside, maybe tube displacement, or it will be too inside, endobronchial. All these things can be identified using the ultrasound. So this is what happened. You can see a double tube side. You can see an esophagus which is distended with the endotracheal tube here. The moment you see this, you don't have to think much. Remove the tube and replace the tube into the trachea. This is how I identify the wrong placement of the endotracheal tube. So once You intubate the patient, you confirm the endotracheal tube is within the trachea by using this bullet sign. You can see one shadow here. If it is esophageal, there will be two shadows. Remove this tube and replace it. If the endotracheal tube is inside the trachea, the second step is, the most important thing is, you do a lung sliding sign. Make sure that the left side chest is not moving, only you can see the air entry. That means there may be a chance of endobronchial intubation. If there is a beautiful lung slide on the left side, that means lung is ventilated. Both the lungs are equally ventilated, tube is in the right position. If there is absence of sliding here, and there is something called as a lung pulse, where there's a rhythmic movement of the pleural line along with the cardiac oscillation, which can happen in case of endobronchial intubation or a massive collapse or a atelectasis. That can be a characteristic feature of endobronchial intubation as well. So this is how you use the ultrasound to look at the endobronchial intubation as well. Even the hemidiaphragm movement. So nowadays we're using the ultrasound to look at the diaphragmatic movements as well. So if the lung is ventilated well, the diaphragm moves downwards. But if you place the endotracheal tube in the esophagus, there is a paradoxical movement of the diaphragm. It can move upwards because of the distension of the stomach down. So that can be an indirect indicator that your tube is in the wrong place. So this is all the features: a double barrel sign or double tube sign, absence of lung sliding, double tube sign confirm the tube is in the esophagus. Then you place the tube properly in the trachea. If it goes endobronchial, then you look at the lung slide. Absence of lung slide indicates good ventilation. If there is a lung slide and the lung pulse, it indicates there is endobronchial intubation. Pull the tube a little bit back. Look at the diaphragmatic movement simultaneously. If there's a paradoxical diaphragmatic motion, again, there is a possibility of endobronchial intubation. So not only the ultrasound use doesn't end here. You know this patient is a trauma patient and he is desaturating, and you confirm the tube is inside the trachea, and you know the tube is not endobronchial, but still you can see this. What is this? You can see a seashore sign, and you can see a barcode sign, and you can see a demarcation between here. This is nothing but a lung point. This confirms the pneumothorax. This patient can have a pneumothorax. He can have multiple rib fractures. Probably hypoxia and hypotension is because of the pneumothorax probably going into attention pneumothorax. So ultrasound again guides you. You don't have to wait for the X-ray. You don't have to rely on the auscultation. It guides you for further management. There was a huge pneumothorax in this patient. An ICD was put. Patient got better. Again, ultrasound use doesn't end there. You can use it one step further. If the patient has a trauma and extensive oral or mucosal bleeding and you can't intubate this patient, there is definitely there is no way the tube is going in endotracheally. You can do a cricothoracotomy by using ultrasound puncture, ultrasound guidance, and you can get airway access in an emergent way. So that's how you use the ultrasound in a meticulous fashion and make use of this wonderful instrument and do the airway assessment and airway management a very meticulous way. So this tracheal ultrasound has been included in the recent AHA guidelines as a method to assess the ETT placement after intubation. Excellent accuracy for esophageal intubation detection. It can be used when the results of capnography are equivocal. You can't get the readings because of so many other reasons, a cardiac arrest, low perfusion state. So we can use it. It can be performed in real time as the tube is advanced into the trachea and the esophagus. Esophageal placement can thus be identified before, and you can avoid artificial ventilation so that you don't cause stomach distension and cause aspiration. It can be performed during CPR without interrupting the chest compressions. We don't have to try to auscultate the patient after the endotracheal tube and avoid the CPR or interrupt the CPR. We can just put the CPR continuous, put the probe in the trachea and confirm the endotracheal tube placement. But the most important thing is don't use it as an alone, use it as in conjunction, use all the technique. You can see the direct vision, use the ultrasound, use the ETCO2, use it in conjunction, which will be a better predictor of right intubation or correct intubation. So that's how the POCUS guided airway management is being done. There is a lot of areas where ultrasound can help us. I'm sure things are evolving day by day and we'll find newer techniques, and ultrasound is a good guide. Maybe go through the videos. There are a lot of videos where you can actually revise these things so that you can understand things better and make use of this ultrasound in a better airway management. And again, I thank you, Forum, for giving me the opportunity to speak, and I'm happy to take the questions.
Thank you, Dr. Himal. That was a wonderful presentation of use of airway ultrasound. You summarized the concepts very well, right from anatomical basics of identification of the cartilages, and then the uses of ultrasound mainly to perform the tracheostomy, the percutaneous tracheostomy, assessment for difficult airway, and other uses like in a difficult airway, you're performing a thyroidotomy, and assessment for post-extubation stridor. Just a question from my side: do you use both bronchoscopy and ultrasound in your setting? What do you do when you do a tracheostomy?
So we are fortunate to have a bronchoscope, Dr. Shiva. So we use bronchoscope,
Okay.
but ultrasound is also a part of it. So first we do is we screen the pretracheal vessels by using the ultrasound, and also we mark the landmarks.
Okay.
And we also use the ultrasound probe to pull the tube out so
Okay.
that the cuff is not near the trachea. And once you do all that, then we pass the bronchoscope. And actually, bronchoscope is mainly used to look at the needle placement and the guide wire placement. And then we perform the percutaneous tracheostomy. And we reuse the ultrasound and scan the lungs again to make sure there is no pneumothorax.
Okay.
But generally, the guidelines say that if you don't have a bronchoscope, we may not need it. What we have seen practically is, suppose you have a bronchoscope and you try to see the monitor, you try to do the tracheostomy down.
Okay.
Generally, the technique and all may become a little difficult.
Right.
But if an ultrasound probe in the hand and you actually look at the trachea and you're stabilizing it and doing it, that becomes a better technique.
Yeah. We have some many questions, Dr. Himal. First question is, how do you anticipate post-extubation stridor if you have intubated with a non-cuff tube? So we have assessed, you spoke about deflating cuff and checking the inflation. So I think maybe in pediatric setting, they use uncuffed tube. So
Yes.
is that method to anticipate post-extubation stridor with ultrasound with uncuffed tube?
That's a good question because even I haven't thought about it. But I don't think that cuff tube and uncuffed tube may not be able to give you a better picture. Whatever the air column width has been done, difference, it has been done with cuff and cuff deflation, as far as I have read through. Then only you can make it, you can know about the air column width difference when the tube is in situ. Otherwise, it has to be when the tube is out. No, you see the air column width when the tube is inside. You extubate the patient and you look at the air column width. And if there is a difference, that indicates that the patient can have extubation, post-extubation stridor. But if already extubated the patient, what is the use of knowing this post-extubation stridor? But that also has been done. There are a couple of studies where they have actually done a measurement with the tube in situ. They have taken the tube out and they have measured it. And again, they have correlated that if there is a width difference, there's going to be a extubation, post-extubation stridor. But we generally do it with the endotracheal tube with the cuff. And we are more of an adult unit, so we haven't have an experience through that.
The next question is, can we determine the size of the tracheostomy tube with ultrasound? I think before
Yes.
the tracheostomy, the question by Dr. Abhay Prakash is, can we determine the size of the tracheostomy tube?
Yes, I've shown you the slide also. So what you do is you do a transverse sweep and you look at the size of the cricoid cartilage. You go through you look at the cricoid ring, take to the cricoid ring. I'll take you through the slide here. So you put the probe in the transverse position, look at the cricoid cartilage. And once you get that view, you can actually have a measurement of
the trachea.
Generally, the subglottic area is the one which is the narrowest part. And if you can have that measurement, then you can actually measure the endotracheal tracheostomy tube cuff size also. Just a second. Sure.
Yeah.
So you can see it here. Can you see that, Dr. Shiva?
Yeah, we can see the.
This is how you measure the diameter.
Yes, the level of the cricoid cartilage.
Yes.
Yeah. Next question is, so how to assess, how to differentiate between false and true vocal cords with ultrasound?
Okay, again a good question. So you need to go to this wave, same horizontal position, and you have to put the probe at the thyroid cartilage, and you can see the thyroid cartilage here, and you can see the arytenoid cartilage here, and this wave, you can see the arytenoid. You can differentiate between the thyroid vocal cords and the adenoid cartilage by using this way, but it takes a lot of expertise. And this is the way which will help you to find out the true and the false vocal cords.
And how to assess epiglottis and hyoid assessment? Maybe you can have an image. I can show the hyoid and the epiglottis. There was a question by Dr. Bhavana.
Hyoid and epiglottis forms a basis of one of the assessment for difficult airway. This is just to show you that subglottic diameter in assessing the endotracheal tube size in case of pediatrics also, not only tracheostomy tube. Hyoid assessment is, so there's a suprahyoid wave, and this is how you see the hyomental distance. You can see the distance here. This is the hyomental distance. And if you look at the thyrohyoid wave, you can see the thyrohyoid wave. You can see the distance between the skin and the epiglottis here. The distance from the skin and epiglottis also forms one of the major bases for difficult airway assessment. You want to contribute anything, Dr. Shiva, to this?
Yeah, I think that was fine. So is there any other questions from the audience? If there's any doubt, you can ask. With regard to airway ultrasound, is there any comments? Kanchi sir, any comments?
Yeah. Himal, that was a very good presentation. Actually, I would say outstanding presentation. Thank you for that.
Thank you, sir.
All the important aspects of ultrasound and airway has been covered very well. And important points you also stressed and repeated wherever necessary. That's very good. Only one point I would like to add that is that we use a lot of one lung ventilation in the cardiac operating rooms, especially when we do the minimally invasive cardiac surgery using a thoracotomy approach, either for left-sided thoracotomy for CABG or right-sided thoracotomy for mitral valve or tricuspid procedures. In these patients, we usually use blockers, that is endobronchial blockers, either on the left and the right side, depending upon which side you're doing. There also we have found that ultrasound is not inferior to bronchoscopic confirmation of the position of the bronchial blocker. So this is one more thing which we are doing it. Other than that, I have nothing else to say. It was well done. I think this. Let us go to the chat box and see if there are any other questions.
There is one comment by Dr. Ratan. It can be used to assess the gastric content as well. Maybe patient with the ultrasound you're assessing airway, the same probe you can just quickly go to the abdomen and assess if there is patient's stomach is full. And Dr. Kollichalam here also has a in a patient with cardiac arrest, it can be used to distinguish between true asystole and for maybe patients arrested, you're doing CPR with aiding in intubation. It can be also used to assess the cardiac status as well, whether you have a ROSC or not. And that definitely that is other use of ultrasound as well in such a scenario. So
yes, I think Dr. Kulicharam has an extensive experience in the airway management. I'm sure that is a wonderful suggestion. So that's what when we try to do CPR, you would have seen it practically. We put an endotracheal tube. We actually interrupt the CPR to confirm the tube by doing auscultation. And it takes a lot of time. So I don't think we should do it. If you have an ultrasound probe next to the bedside in emergency, you can use it in multiple situations. The first thing is the endotracheal tube placement. Simultaneously, you can also look at the lung sliding there and also look for pneumothorax or again endobronchial placement of the tube. It can be a good guide. And also other causes of cardiac arrest can be determined by using the same ultrasound machine.
And there's a question, Dr. Himal, which is better for ET2 placement? Which is the lung slide or double barrel sign?
So it's good somebody asked that question. Let me clarify it. So ET2 placement is double barrel sign. I'll show you. Lung sliding is just to look at the endobronchial intubation aspect. So if the endotracheal tube is outside the trachea, that is in the esophagus, we get this double barrel sign. So you need to replace it back into the trachea. But lung sliding scan is if you have put the tube already in the trachea, but it has gone into endobronchial side. Of course, you don't have an air entry on the left side, but you can ventilate only on the right side. So you have a lung sliding, absence of lung sliding on the left lung. That indicates that there is no ventilation on that side, so you need to pull it out. So that is the main idea of doing the lung sliding technique.
So can we make out ET tube block with ultrasound? I think patient has a tube block. I'm not sure. Himal, you should be.
I don't think so, because I think I haven't heard about it. You can't make it out. It means more of a clinical identification.
So there's no other questions. I'd like to close the session. Thank you, Dr. Himal, and
Thank you.
thank you, sir, for the opportunity.
Sure. Somebody has asked about what probe do you use?
Yeah, I just I just put in the comment section. It was a
frequency probe which is being used, not the abdominal probe.
Yeah.
Thank you, Shivakumar and Himalya, for that excellent webinar on ultrasound for airway assessment. Very well done. And I would like to thank both of you for joining us this Sunday. And we look forward to having you once again sometime later. Please join us then. Before we actually close, I would like to make a couple of announcements. One is that the requirements for the fellowships, you have to write on a monthly assignment, and each topic for each month is already distributed. And you have to attend at least 3 workshops just to ensure that you have undergone a structured training program. You have to maintain a logbook for X number of cases done, which is certified by your local mentor. And webinar attendance of up to 80% is mandatory for you to take the examination. And this August, we have the International IACTA TE seminar, the workshop at Bangalore. Dates are 21st to 24th. For those of you who are doing fellowship, it is mandatory because this will be considered as a contact session, because we don't come to interact with you on a daily basis. We would like to see you that time. Please register and participate in the workshop, which will be of a very high quality with all experts from all over the world joining us. And with that, I would like to thank you once again. And I don't know whether Ritu has the video for the workshop.
Yes, sir. Yes, sir.
That's the last bit of this session, and thank you so much.
So with all your permission, I would like to present it, sir.
Yes, madam. Thank you so much. Enjoy your Sunday. See you again next Sunday. Thank you.
Thank you, sir.
Thank you, sir. Thank you. Happy Sunday.
Thank you, dear doctors, for sharing such valuable insights. I hope you had a seamless experience. So, with all your permission, then we are signing off for today and looking forward to host you again very soon. Goodbye. Take care.